Okay. Well, welcome everybody. Thank you so much for joining us this morning for our Frankly Speaking and about prostate cancer with Dr. Zhang. We're so excited to have you here and bring this topic. I don't think we've had this one yet, so we're pretty excited to be presenting this today. So we'll go next slide. So these slides were reviewed by Dr. Denise Min, it's my best guess, in 2019, and then Dr. Zhang kind of went over them just this month and modified them. So I just want to go over, well, first, before I go over the housekeeping, I'm just going to go over our cancer support community and just introduce myself. I'm Caitlin Graves. I'm a social worker at Northwest Medical Specialties and also a member of Cancer Support Community. And Cancer Support Community is the largest professionally led nonprofit worldwide, and they bring support, free support, so that nobody faces cancer alone. And we're so excited to be partnered with them and continue our partnership with them, because then we're able to bring, you know, workshops like this to you guys, support groups, you know, resources, social events. So, you know, keep looking for our stuff. We're always having things coming up. And at the end, Abra will go over more of our upcoming events happening this month and next month and so forth. So just for a little housekeeping. So we do ask that everybody stay muted throughout the presentation, just so we can kind of keep that background noise down. And we have allotted time at the end to answer questions, but we do have the chat box, which you can see on your screen. So if you do have a question that kind of comes up through the presentation that you don't want to forget or want to have answered, definitely just put it in the chat box. Somebody will be monitoring that. We'll make sure it gets answered at the end. So best viewing option is the speaker view, which you can change at the top. If you're on like a laptop or desktop, you can kind of change the view, and speaker view is the best. You can usually do that at the top right of your screen. And then slides will be made available after the presentation. We can email those out to everybody. So I'm going to introduce Dr. Zhang. I'm just going to read through this left side of the slide here. So Dr. Zhang is a board certified and fellowship trained oncologist hematologist. She completed her fellowship at Dana-Farber Cancer Institute at St. Elizabeth's Medical Center in Boston. During her fellowship, she worked closely with the field leaders, Dr. Christopher Sweeney, Dr. Mark Pomerantz, and Dr. Guru Sambhavi at Link Center for I'm so sorry, oncology at DFCI. She also worked on clinical research in prostate cancer, which was presented at International Meeting of American Society of Clinical Oncology. After completion of fellowship, she worked at Geisinger Medical Center for 2 years, focusing on treatment of GU malignancies, building GU multidisciplinary clinic, leading immunotherapy side effect management working group and pathway development, as well as involving in fellowship and resident education. The research project on bladder cancer she proposed was presented at American Society of Clinical Oncology meeting. She has been with Northwest Medical since July of 2020. So without further ado, I'm going to welcome Dr. Zhang.
So, April, do I have the control now? Hi, can you hear me okay?
Yes.
Oh, okay.
Yes, sorry, Dr. Zhang here. I'm giving it to you right now. So you should have it now.
Okay. Okay. Yeah. So first of all, thank you very much, everybody, for joining us today. So the goal of today's talk is to increase prostate cancer awareness. We will talk about what is prostate cancer and why it is so important. What are the potential symptoms that patient could have? How do we do prostate cancer screening and find it earlier in the process? What are the available treatment options? And who are the care providers that were involved in the treatment of prostate cancer? At the end of the session, we will take questions. And let's get started. So first of all, let's talk about, what is prostate, right? Only men has prostate. So like a female is not going to have prostate cancer. So it's a walnut-shaped gland in the male reproductive system. It sits right below the bladder and connected with penis, the urethra, and in front of the rectum. So as you can imagine, I'm trying to use a little purple arrow to draw, the location, if you can see that. As you can imagine, if there is a tumor in the prostate gland that is enlarging, the mass effect can make the urinary tract, right, very narrow, and the patient could have trouble urinating. So, and if there is a tumor in the posterior area of the gland, then that can cause, if it's big enough, can cause mass effect in the rectum. Patient actually presented with, constipation or rectal irritation symptoms. That means, you want to go and have a bowel movement, but you actually cannot make one. So, so prostate cancer, right? Cancer, in a simple words, would be uncontrolled cell growth. Also prostate cancer shares very common symptoms with prostatitis or BPH. However, because it's uncontrolled cell growth, right? If the prostate cancer get untreated or unnoticed for a long time, then the cancer cells can grow, invading and spread through blood vessel and the lymph system. So the most common places for prostate cancer to go are the lymph nodes, the bone, the lungs, and the liver. So if patients have prostate cancer in the bones, they can have bone pain. And in later stages, they can have weight loss or loss of appetite. So why this is so important, right? Why do we want to know about it? So 1 out of 7 men will be diagnosed with prostate cancer in their lifetime in the United States. And for African American, it is 1 out of 5. Especially for those who are smokers. For patients whose fathers or brothers were diagnosed with prostate cancer, the incidence, the chance of having prostate cancer is 1 out of 3. Based on the newest SEER database this year, so roughly around 250,000 men will be diagnosed with prostate cancer in 2021, and over 35,000 of them is going to die from this disease. And here I want to mention that breast cancer, right? It's 1 out of 8 in United States. But, I guess, women are better in terms of advocating breast cancer and for themselves. So I think we can do more work so the prostate cancer can catch up. So, the highest risk patient population is going to be who are with family history, especially whose brother or father diagnosed with prostate cancer at a very young age, less than 65, or, African American ethnicity. So the symptoms I already touched upon a little bit in the anatomy part. So in very early stage, as you can imagine, if the tumor is very, very small, patient may not have any symptoms at all. As the tumor grows, it can compress the urinary tract and cause urinary symptoms. For example, trouble of urinating, the feeling of unable to empty the bladder, urinating less than every 2 hours. They can have pain, and they can, have strain or weakened urine flow. So, because prostate cancer, BPH, and prostatitis, they can have very similar clinical presentation. So a lot of patients can have delayed in diagnosis because it was mistaken by other benign etiologies. And if the cancer gets very big, and patients could have bone pain, and if the cancer invading the bladder, they can have blood in the urine. So that tells us, it's very, very important, right, to find this cancer earlier in the course so we can cure more patients. In the left side picture that you can see, especially from, before 2005, so the incidence of prostate cancer is actually pretty high because what every man get like a PSA screening at that time, almost. And then they found that, with unfiltered PSA screening, a lot of patients are actually diagnosed with low-grade Gleason 6 prostate cancer, which doesn't need to be treated for. And then they went through all the blood testing, biopsy, anxiety, et cetera, et cetera. So in an effort to decrease the overdiagnosis, and USPS task force recommended against, PSA screening for people who are age 75 and older in 2008. However, with a shift in recommendation in PSA screening, on the left side, we can see that either in younger patient population or older patient population, right? So more patients are diagnosed, with more advanced disease. So those were at least node positive disease. And as we know that node positive disease, unless it's in the pelvis, we can still try to entertain the idea of cure them. It's essentially an incurable situation, right? So, based on this information, and there are again some shift in the guideline recommendations. So right now, the American Cancer Society screening recommendation. So for men with average risk whose life expectancy more than 10 years, we start screen prostate cancer from age 50. And for patients who are African American or whose brother or father diagnosed with prostate cancer less than 65, the screening age starts 45. And if the patients who had more than one first-degree relative diagnosed with prostate cancer at a young age, we recommend start PSA screening start at age of 40. Those are screening guidelines, right? Screening guidelines. I want to emphasize again and again that for patients who are in the right age frame, right, and have urinary tract symptoms, for example, the symptoms we listed, or suddenly increase in your urinary pattern. For example, it's normal to have to urinate once or twice after age of 50. But if there is a sudden change in your urinary pattern, you have to get up in the middle of the night 3-4 times in the past 3 months or 2 months to pee, that's not normal. And this is not screening. This is workup, diagnostic workup. So a patient age 30 present with urinary symptoms unlikely to have prostate cancer. However, patients are like in their 40s or 50s, we need to pay close attention to. Those are not considered as screening, they're diagnostic workup. We should rule out prostate cancer. And the symptoms, we already mentioned about it. We will skip this slide. So how do we screen prostate cancer? So, we can do a digital rectal exam and trying to feel if there is any nodule or mass through the rectum. We do a PSA testing. Also, it's not a perfect tumor marker, but that's still the best tumor marker we have in solid tumor. And if the suspicion is high enough, and so we would proceed with a prostate biopsy. Now we request, 12-core biopsy, which is usually done by urologist. So the benefit of screening is really trying to diagnose more patients at early stage so we can cure them, right? So the potential risk of screening is going to be overdiagnosis. That is one we worried about the most, especially for patients in their, maybe late 70s or 80 years old with a lot of other comorbidities. To diagnose with low risk prostate cancer can add unnecessary blood testing and biopsy, anxiety, etc., etc. Here I would stop and I will welcome our patient guest speaker, Larry, to share his own story so you can have a better understanding about what are the potential symptoms for prostate cancer. Larry?
Thank you, doctor. I appreciate this opportunity to share my story. It's as I did some research on my own life, I realized that I had a lot of signs that I wished I would have gone to the doctor sooner on. So first of all, I'm a 65-year-old Caucasian. I worked in the construction industry for 40 years. I'm a superintendent of construction now. I've worked hard my entire life. I have a lot of back pain. I have a lot of arthritis pain. And so some of my symptoms started probably a year ago with simple erectile dysfunction. And so I went to my doctor, my regular general care doctor, and he prescribed some testosterone shots, and they were painful and didn't really do anything for me. So I, of course, as a leader of men, I decided to lead my own self down my own health path, and decided to take some testosterone supplements from a local medical generic medical supply store. I went through that process for a number of months, which actually I think caused me more problems. And so my urinary tract started having issues, not being able to urinate properly. It didn't resolve any of my erectile dysfunction, and that continued to get worse over the period of most of the year of 2020. By the time we got into the fall of 2020, I was getting up several times during the night, going to the bathroom. Finally, it got to the point in, I think, October of 2020, where I got up one morning and I couldn't go to the bathroom at all. And so I went to emergency room. They catheterized me, put me, I had, nearly 2,000 milliliters of urine in my bladder. And from that point on, I've been self-catheterizing. My diagnosis was confirmed in December, early January, and started treatment in February. And we had great CT scan results by the 1st of June. So A little bit more background information was that my own self philosophy is that I'm going to try to fix myself. And of course, I utilize what everybody calls Dr. Google. And of course, that's a bad thing. But it did give me a lot of insight on many different ways of treating myself. Obviously, Dr. Zhang has done a great job with me, but I also forced myself to eat. I forced myself to exercise extremely hard at times. I pushed myself to experience a lot of adrenaline, excitement, jet skiing, snowmobile skiing, trying to make myself burn out the chemotherapy, I guess you might say. But certainly keeping my appetite up, eating a lot of red meats, steak for breakfast and steak for dinner. I felt that was one of my best ways to keep my nausea away, was a full stomach on heavy red meats. Nothing else. The nausea medicine didn't seem to give it much help. So anyway, luckily, doctor has gotten me to this point where my CT scan shows that I'm in a remission state. The swelling of my prostate's gone down, and I'm now moving forward into a what I call belts and suspenders program, in that we're going to start radiation now in July, and we'll go through 25 or 30 radiation treatments just to ensure that this nasty beast doesn't come back and bite me again. That's about it. Thanks, Doc.
Thank you so much, Larry, for sharing your story. That's great. That's great. Thank you so much. So from here, I will continue to talk about, so if, one has been diagnosed with prostate cancer, how do we decide, the treatment plan, right? So as for all solid tumor, staging is very important. Staging means to see a clear baseline. What is the primary tumor size? Okay. Is it invading any surrounding structures? Is there any metastasites, right? And we normally do a bone scan, CT scan, and for most localized prostate cancer, we do prostate MRI, which can help with surgical planning or radiation oncologists trying to target the area. So based on, the pathology biopsy and staging, and pre-treatment PSA, et cetera, we divide patients for localized disease, right? Low risk, intermediate risk, and high risk group. We treat patient according to their disease characters, the sense that I mentioned, and also patient's characters. For example, their age, their preference. So some patient will say, okay, I don't want, radiation. Some will say, okay, I don't want surgery. And also, does the patient have any other comorbidities, right? Other medical problems that will interfere our, decision making. So the goal for prostate cancer treatment for localized disease, right? Localized disease means the prostate cancer has not gone to other places, is to cure the disease. So it's not going to come back again. And for patients who have metastatic disease, and especially distant metastatic disease, we currently do not have the cure yet. So the goal of the treatment is to help patients to live better and live longer. The one thing I want to emphasize again, the reason why we want to screen people, because we want to find the cancer earlier so we can cure more patients. So what other doctors will be involved in the treatment for the prostate cancer? So for localized disease, right? If the disease is confined in the prostate or just in the pelvis. So those are the those are the doctors will be involved, medical oncologist, somebody like me, specialize in treating cancer with hormonal therapy, chemotherapy, or immunotherapy, and targeted therapy, manage general medical problems during the process. I normally tell patients that, as a medical oncologist, I'm your friend and I'm your quarterback, right? So you might have been seeing your primary care doctor for the past, 30 years. But once you diagnose with cancer, especially cancer-related problems, symptoms, or side effects, treatment side effects, so your medical oncologist would be the person you want to call because we're specifically trained for that. And the radiation oncologist is to use radiation. It could be extra beam radiation or some fancy radiation like gamma knife, et cetera, to treat cancer. And urologists, are the ones, are the surgeons in treatment of, cancer, including prostate cancer, bladder cancer, testicular cancer, and kidney cancer. Yeah, so in terms of localized disease, and as we mentioned about for patients with very low risk disease or with a lot of other medical comorbidity and limited life expectancy, we sometimes use this what we call active surveillance. Active surveillance is not watch and worry. Active surveillance is to do PSA testing, do digital rectal exam and pelvic MRI and repeat biopsy, and started the treatment if there is any suspicious sign that the cancer can be growing and causing trouble or becoming more aggressive. So radiation therapy is use the energy of radiation trying to cure the cancer. And when patient with intermediate risk or high risk of prostate cancer, we normally pair hormonal therapy, what we call androgen deprivation therapy, ADT, along with radiation to increase the chance of cure. And radical prostatectomy is to take out the whole prostate gland, and they would do lymph node dissection in the same procedure as well. There are different ways of doing radical prostatectomy. One way is to do open surgery like the old way, and right now a lot of surgeons are doing robotic assisted prostatectomy. So this we have already talked about. One thing I want to emphasize is, prostate cancer is a very tricky disease because, localized disease can be cured, right? The thing we really want to modify or mitigate is the treatment side effects. So your care team should involve medical oncologist, urologist, radiation oncologist. So we call it multidisciplinary care in this disease. So, as you have heard about from the beginning, I joined Northwest Medical Specialty from July last year. And I have been working closely with radiation oncologists and urologists in the CHI system. And I proposed a geo tumor board in the CHI system, and it has been up and running. We have a lot of good discussions, and now it's official. My goal in the future is to build a multidisciplinary clinic in the area if possible. So we can, advance the care for our prostate cancer patient locally. Here, I want to talk a little bit about systemic treatment, right? Systemic treatment in prostate cancer can be divided. Okay, is a systemic treatment with hormonal therapy to go along with a radiation to make the radiation more effective, or the patient has more advanced disease or what we call metastatic disease that deserves that needs to be treated with hormonal therapy. Or ADT, another word to, for the same treatment. And we treat chemotherapy, immunotherapy in metastatic prostate cancer. What we have right now is Provenge. So a lot of patients are interested and ask me, okay, I see a lot of advertisement right now about Keytruda, right? Do you use that to treat prostate cancer? So I know, immunotherapy or checkpoint inhibitor has been, used or has have made a huge change in the lives of cancers in many different ways, including lung cancer, melanoma, kidney cancer, bladder cancer. But so far, checkpoint inhibitor in prostate cancer is still an area of ongoing clinical trial. We don't have a home run yet. There is some data that use bipolar androgen therapy along with immunotherapy might be the way to go, but we don't know. We will still see how everything comes along. But the mainly immunotherapy in prostate cancer right now is Provenge. We talked about systemic treatment, and so one thing about regular prostate cancer. Okay, regular prostate cancer we talk about is prostate adenocarcinoma. We know that this is a type of prostate cancer fuels on male hormone testosterone. So that's why, in treating of the cancer, we want to take away the testosterone. So to treat the cancer, with this therapy, we call it androgen deprivation therapy. So there are two ways of doing androgen deprivation therapy. One way is to do surgery to remove the testes. So there is a majority of the production of testosterone will be removed through orchiectomy. And another way of doing it is through, the shots. We either use, Lupron shot or Edgar shot or Firmagon shot to tell the pituitary gland not to stimulate the testes to make testosterone. For metastatic disease, sometimes we use chemotherapy as well. There are two agents that we used in prostate cancer pretty commonly, docetaxel and cabazitaxel. A lot of patients may have the fear of chemotherapy, but I can assure you that so right now, how we give chemotherapy is very different from what you heard, your parents or your friends who had cancer 20 years ago, how they were treated. So we treat most of our patients in the clinic. So they have the chemo infusion for several hours every 3 weeks, normally for those two chemo agents. After those several hours, you go home, and 3 weeks later, you get the second round. During the 3-4 hours chemo treatment, you'll be in the clinic, and you can just put your feet up and relax, or you can read a book, or you can watch a movie. We have better ways to manage the side effects as well. So for example, nausea, vomiting, we have stronger and better anti-nausea medication. So that just for your information. And about clinical trials, so we do have clinical trial at Northwest ourselves, and we also have clinical trial through South Sound Care Foundation. So the reason we want to do clinical trial is to try to help patients to find new treatment options, and at the same time advance the science and help others, right? So and I work very closely with SICA, SCCA, so UW GU oncology group, for some of the patient, if they need more treatment that are not available locally, I would not be hesitant to send them to SICA for clinical trial options. The most common side effects for prostate cancer related treatment side effects, right? This is more for localized disease. So for patients who are going to have radical prostatectomy or radiation, two common side effects are erectile dysfunction and incontinence. So I would advise again, so all patients with prostate cancer should be seeing medical oncologist, radiation oncologist, and urologist, so you get a general idea what are the options, what are the side effects. So you want to be well informed before you choose which way to go. And we normally refer patients for pelvic physical therapy, so they do Kegel exercise and train you for that, and have you to prepared, and incontinence we manage, and the urologist usually help to manage the incontinence part. And if the patient are either with because of very advanced age or a lot of other comorbidities, and have gone through multiple lines of chemo treatment, and would like to focus on quality of life, in that stage we would refer patient to palliative care and hospice, and make sure patient is well supported so they can focus the time they have with their family. And there are some options, and some you can call to get to talk about your treatment options. And we already talked about the healthcare team for second opinion. As I mentioned, right? I'm happy. I'm here. I'm happy to help in any way. And if you would like to get a second opinion, just to make sure you're making the right choice. And I work very closely with UW GU oncology group, and I will be more than happy, to refer you to them for a second opinion. So we both have, a peace of mind about the treatment. And the next thing that I want to emphasize is genetic testing about prostate cancer. So right now, NCCN guideline, right, recommend high-risk prostate cancer and very high-risk localized prostate cancer and metastatic prostate cancer. You should have genetic testing, because we found that roughly around in metastatic prostate cancer, roughly around 12 to 15% of patients who are actually carrying BRCA mutation. For those of you haven't heard about BRCA mutation, you probably know about Angelina Jolie, the famous actor, right? The famous actress. She had BRCA mutation. She actually had bilateral metastasectomy, so removed her breast to prevent breast cancer. So people who have BRCA mutation, depending on BRCA1 or 2, they're more likely to have, GI, GU cancer and the melanoma and other pancreatic cancer, ovarian cancer. So we do emphasize those patient population get genetic testing. Ashkenazi Jewish genetic testing and the family history with BRCA mutation, Lynch syndrome. So, for patient who have their father or brother or uncle, multiple family members diagnosed with prostate cancer or lethal prostate cancer at a young age, right? Those patients needs to have genetic testing. So the genetic testing serves the two purpose. Number one is, for you, because patients who are having BRCA mutation, they actually, respond better to platinum agent or PARP inhibitor, so that will give you another line of treatment option. And the second reason is for your family. If you have, kids, right, son or daughter, they would know, and if they carry the BRCA mutation for your son, that would be increased risk of prostate cancer, pancreatic cancer, colon cancer, and for the daughter, that's going to be breast cancer and ovarian cancer screening, so they can screen start from early age and do some preventative measures to prevent cancer occurrence. And I think a question that I get asked very often is, what should I eat, or what should I do to help myself, right? So the general idea is, what you do with healthy living will be good for your prostate cancer as well. And I normally ask patients to eat a balanced, healthy diet. And you should quit smoking. And some patients ask me, okay, I search online and they said, cancer patients should not eat sugar. Is that true? So should I cut down my ice or bread? I think that's totally unnecessary. I think, there is some hypothesis about sugar and cancer recurrence. So the notion is, if you eat a lot of concentrated sugar, what I mean, like ice cream, candies, cookies, and cakes, right? Eat a lot every day from an early age, from childhood, right? So each time, so our body has a tendency to keep your internal environment stable, trying to stabilize your blood sugar. So it started to release a lot of insulin, right? And to control the blood sugar. During this process, insulin and other growth hormones will be released. During the course of years and decades of this high blood sugar stimulation environment, that could, cause cancer to happen. But, once you have cancer, I'm not sure to avoid sugar would, help you tremendously. What I mean is, I'm not encouraging you to eat a bowl of ice cream every day, but I'm just saying that, if you like rice, we're not going to take your rice away from your diet, and you just control the portion. If you eat ice cream once a week, or a few times a month, I don't say that's a problem, right? So another question is, should I avoid red meat? I'm not sure, I think cardiologists and maybe other providers would emphasize about red meat. I think it's okay to eat red meat. I actually sometimes encourage my patient to eat red meat because that will give you a lot of iron and help patients who are needing to go through chemotherapy tolerate the chemotherapy better. If any food that you should not be eating, I would discourage, fried food, canned food, and heavily processed food, right? The food that you can eat, like homemade fresh food, would be the best. I think with that, I'm going to just conclude. The reason why we want to do prostate cancer screening is we want to diagnose more patients at early stage so we can cure them. And there is some patient population would be at higher risk of having prostate cancer, including those who with family history of prostate cancer and African American ethnicity. And the third is, if you have lower urinary tract symptoms, unable to empty your bladder, or seeing blood in your urine, or you're having urinary frequency, or you need to strain, or there is change in the pattern of your urination in the past a couple of months, like consistently, you should seriously think about seeking medical attention right away. And that doesn't belong the screening patient population. We need to rule out prostate cancer. Again, I'm here to help, and I'm happy to take any questions now.